We appreciate your media coverage. Welcome to our theater. My name is Dr. Ogoe, General Surgeon. Our patient is JMK, a patient with acute appendicitis, and we've scheduled our patient for laparoscopic appendectomy. Initially, the procedure was only being done open, whereby we cut and get a large incision, but we saw that the patients have a lot of pain, postoperative, extended recovery, slow return to work, and unsightly scars. So the world has gone a notch higher in terms of medical technology, and now majority of the operations we do under the laparoscope. But a time comes when sometimes the pathology becomes overwhelming, and sometimes we have to do minus the laparoscopy, but now the world standard is laparoscopic appendectomy. So we've already achieved our open access. We get into the abdominal cavity, we blow a gas called carbon dioxide to make the cavity wide so that we are able to get enough space to operate. Then we go in with the camera, and as I take you around, you can see there, those are some of the organs, the loops of intestines. Yeah, some other organs within the cavity, like there I go up, you see the liver, the gallbladder, and so on and so forth. I can just take you with the camera throughout the abdomen there. I go back down to the pelvis, where you can see that is the pelvic cavity, loops of intestine. Sorry for that. And laparoscopy is good because once you get your camera into the cavity, then you're able to scan the whole of abdomen. And if there's a pathology somewhere, irrespective of what you had already known before bringing your patient to theater, then with your OK, then you'll be able to access it. So we have our camera in place, but we cannot just work with the camera alone. So we'll need to create more port positions so that we are able to get our instruments to go in. Thank you.
All right, so as we continue, we definitely will be asking a few of questions.
Thank you.
If you would allow us to, Dr.
Yes. Pleasure. Put 10. Put a 10. Come hold the camera for me.
So, Dr. at what point does the doctor then prescribe that one has to go through an appendectomy?
Appendectomy basically just means inflammation of the vermiform appendix. And it is the pain. Actually, majority of the patients come to the hospital because of pain.
Okay.
And when patients present you with pain, you assess them. And as we know, if the inflammation continues unabated, then we are most likely to get things perforating and pouring a lot of fecal matter into the abdomen. So we get it early. We want to try and go in as early as possible so that we prevent that from going in. Of course, most of the patients will come with pain, vomiting, loss of appetite, hotness of body. Yeah.
What do you suppose would trigger that? Foods, what it is that we eat, or what?
An appendix is an hollow organ. Basically, it has a cavity just like the other parts of the intestine.
Okay.
And when the cavity is blocked, it can be blocked by food particles, by fish fecal matter that is hard, or even by worms. And that can stop it from discharging its secretions.
Okay.
And when that happens, then show me that is. Okay. So when that happens, then we get a scenario whereby there's a lot of exaggerated pain within the abdominal cavity, and we call that peritonitis.
Okay.
Yes.
And so at this point, there are no two ways to it. It has to be, like one has to go through the surgery?
Sometimes you can be treated with medication, but sometimes the time comes when the medicine will not be able to work. Show me the camera. So when the medicines are not able to work, then we treat it sometimes with antibiotics, but there's a strict criteria, which now I will not be able to discuss here because it's a short forum. Yes.
Okay.
Yeah. Show me my pot. I'm trying to create another pot for access. I'm trying to create another pot for... Can you see me?
Yeah.
Yes, and the pots are created under vision so that you don't puncture your intestines.
The intestines.
Yes, otherwise if you create them without vision,
Okay.
then you can injure and perforate your intestines.
So at this juncture, the procedure has not begun as
The
such?
procedure has not begun, we're just trying to locate port positions.
Okay.
Yes. Just put it up a bit. Show me. Okay, we are trying to see our other site of entry, which is called a port. Yeah, we are trying to locate it. Okay.
How serious would one consider this procedure to be? Oh, okay.
You can see?
Yeah.
Yeah, that's our. Unfortunately, sometimes.
There's a blade there?
Yes, yes.
Okay.
Yes, and that blade we have to watch it carefully so that it does not puncture our intestines. Otherwise, it's the one that will now do more harm than the appendix by puncturing your intestines. Good. You can see it now. So once we are in, just show me again.
Okay.
Okay. Okay. Okay. Yes, you can see. That's it, I'm playing with it. Once we are in with that, okay, let me just draw in the sharp trocar so that you can see it. There. So once we are in, then you just pull that out so that you don't cause trauma to your intestines. We'll put another one. So we'll put one down, we'll put another one here, the left iliac fossa, so that we have two working pots. The 5 millimeter.
Okay.
Okay.
How long would the entire procedure take?
Well, it depends. Show me. It depends on how fast and how experienced the surgeon is, and also the pathology of the patient. It might take as short as 30 minutes, or it may be as long as 1 hour to 1.5. Okay. Yes. All right. And sometimes you might find that things are so thick that you cannot finish with the scope, especially when you're suspecting maybe there's traces of cancer, or there's what we call generalized peritonitis. And now you deem it that when you try to finish, like you see there, if you go very fast, you may puncture.
Hit the other one, the other side.
So now as I go in, so just go in with that. So concentrate on the bowel around that place, So we concentrate and check. You can see the bowel just below where the place that we've entered in is intact. Otherwise, if you had punctured, you probably would have seen a bleeding, which would be the common thing, and that could alert you to a possible perforation, which would actually pour a fecal matter into the abdomen, and that can actually leave you with peritonitis. You have a scenario where you've sorted your patient, but now you've left him or her with another set of problem altogether. So we are normally careful to really inspect that and see that we've done. Okay. Kindly.
So we've gotten access point number 2.
Yes. So now we are just about to start our surgery. Okay. We have a small problem with our pot. Let my assistant just help me to sort it out. It's leaking
so how
gas
many,
a bit.
all right. Normally you would be how many in the surgery room?
2 to 3 is okay for the operating team.
Okay.
Then, of course, there's the runner, nurse. There's who that can be 1 or 2. Then, of course, there's the anesthesia team and the anesthetist or the anesthesiologist, plus the assistant. Yes. All right.
So at this point, completely the patient cannot hear or feel anything.
Yes. The patient cannot hear. Yes, or feel. Well, but that depends on the levels of anesthesia, and probably I might not be the best person to comment. My colleague, yes, the anesthesiologist might be the one who would be in a better position to comment on that.
But are there instances where the patient would be allowed to see what is happening?
Well, the only thing we do is to record for the patient. Once we record for them, then they'll be able to see, what we have done. Yes.
Okay.
Yeah, so help me with 2 graspers. There's a grasper here. I want to use 2 graspers first.
So are there specific foods that would get someone to this level?
Well, I've heard people talk about popcorns.
You tell us, popcorns.
And appendix.
Mawe for the
women. Whether that is true or not, the jury is out there. Yes, but basically for the pathology of the appendix, we just need to know that as long as there's anything that is blocking the lumen of the appendix, then we are likely to have problems. Yes. Sure. So I will be using 2 operating instruments,
Okay.
one on my left and one on my right.
Yeah.
Yes. And our instruments, okay. So just come out and zoom in on the appendix area. So we'll go to a place called right iliac fossa.
Okay.
Rather, you can see there's an omentum that is really giving you problems. Okay.
Is that a bleed? Like
Yes.
you know, that's
Yes,
blood?
sir. The place where we are able to we put our pots.
Okay.
Yes, yes.
Ah, all right.
Okay, very well, very well. Okay. Okay. So the appendix is normally the area
Okay.
around what you call the cecum. And sometimes when I do this, I might feel that there's something hard. And if I find something hard
Okay.
and more inflamed than the usual appendix,
Yes.
then probably I'll just convert.
Okay.
But if you look at this area, the area there, there's some hardness. Yes, yes, there's some hardness over there.
Yeah.
So we might be forced to actually so I'll try and remove the tissues.
Okay.
Yeah.
So you get to the appendix
Yes.
itself.
This one is loop of small intestines. This is the cecum.
Okay.
And then there's a mass over here.
All right.
So we'll be checking around that area to see what we have. We just do small probing, yes, movements. Rather, there's some very hard mass over here. Yes.
Okay. It's what is making the equipment kind of slide, yeah?
Yes, yes, this one. This hard. So it may be pass. Yes.
Maybe pass?
It may be pass.
Okay.
Yes, yes. Okay.
What would happen if the appendix were to burst?
Then you'd have a lot of infection around it. You'd have a lot of pus within the peritoneal cavity. And that would give you something called generalized peritonitis.
Okay.
Yes, the appendix there seems to be a mass in the area around here. And as you see, as I try to manipulate around there, there's a bit of bleeding. So I'll just try and become careful. Yeah, so that not to cause the patient a lot of... These might actually be the appendix.
Okay.
But it is tightly adherent to the wall around there.
So makes the process more complicated?
Which one? This one. This is a loop of small intestine. This one. I do not want to grasp them because I will cause a bit of trauma to them. Yeah, this is a loop of small intestine, and the appendix seems to be within the mass around here. So I'll just try and maneuver this slowly and carefully and see whether we can separate.
After the surgery, they would experience pain?
A little bit of pain.
In the event of a burst, one can survive?
Yes.
Okay.
Majority of the patients survive unless you come to the hospital late.
Okay.
Yes, I'm just trying to hold this up so that we can see what else is here.
Wow.
If we find that the inflammation is a lot, that we are not able to work on it with the scope, like here I'm seeing there's like a mass. Yes, there's some.
The yellowish
This
bit,
one, you
yeah?
see this?
Yeah.
There's a hard mass over there, and I'm not sure whether that is really the appendix itself per se. It could be something called an appendicular mass.
Okay.
Bring the ligature. So I'll withdraw my instrument
Okay.
and bring.
Different ones. Okay.
Well, that is what we call bipolar. Bipolar.
Okay.
Get us a name. We will see whether we need a monopolar or not. That one, there. This is a very huge loop. Hiyo ni loop ya ilium. Hiyo ni loop ya ilium. The appendix iko kwa hiyo mass.
All right, maybe we can take a short break on this very note as we await for the surgeon to, and then we pick it up from there after this break.
You are watching. How well do you know what's happening around you? Morning Cafe with heated political debates. Baraza la Siasa.
Hiyo kitu azungumzie, angalie hali ya maisha ya watu.
Informative health discussions. Business, farming. Tasty Wednesday, Fitness Thursday, and Feel Good Friday with amazing DJs, celebs,
waimbaji, kuna comedians, alafu kuna wajinga.
and music bands every Monday to Friday from 6 a.m. to 9 a.m. How well do you know what's happening around you? Morning Cafe with heated political debates. Baraza la Siasa.
Hiyo kitu azungumzie, angalie hali ya maisha ya watu.
Informative health discussions. Business, farming. Tasty Wednesday, Fitness Thursday, and Feel Good Friday with amazing DJs, celebs,
Waimbaji, kuna comedians, alafu kuna wajinga.
and music bands every Monday to Friday from 6 a.m. to 9 a.m. How well do you know what's happening around you? Morning Cafe with heated political debates. Baraza la Siasa.
Hiyo kitu azungumzie, angalie hali ya maisha ya watu.
Informative health discussions. Business, farming. Tasty Wednesday, Fitness Thursday, and Feel Good Friday with amazing DJs, celebs,
Waimbaji, kuna comedians, alafu kuna wajinga.
and music bands every Monday to Friday from 6 a.m. to 9 a.m. How well do you know what's happening around you? Morning Cafe with heated political debates. Baraza la Siasa.
Hiyo kitu azungumzie, angalie hali ya maisha ya watu.
Informative health discussions. Business, farming. Tasty Wednesday, Fitness Thursday, and Feel Good Friday with amazing DJs, celebs,
Waimbaji, kuna comedians, alafu kuna wajinga.
and music bands every Monday to Friday.
Mass, it was matted together with the omentum and the small intestines, principally the ileum. So we've dissected it out. This is the appendix, as you can see it. And we've tied a loop to the base. That's a loop of a suture to the base. So now we'll put another loop of suture. Then from there, we'll just be ready to transect the appendix and to retrieve it.
From the burning stage, Dr. that we saw, why not burn to, the entire cut as opposed to tying the loop?
Burning, as you can see, where, sorry, just a little bit of it. You can see where the suture is, the tie here is closer to this organ called, the part of a large intestine called cecum, there. You can clearly see there. You can see, Yes. So what we are trying to avoid is to create energy here, which can actually burn this and lead to a fistula. At this juncture, the base of the appendix is tied well. There would even be no harm. I can actually use even monopolar diathermy, monopolar energy source, to cut this and just remove the appendix. There would be no harm. Yes, because this is well secured. Yeah, but just for safety, I will look to add one more suture to the base. So, okay. So first of all, I'll cut these sutures. Give me a scissor. and remove them. We don't want suture particles inside there.
Which is very, very important in terms
Yeah,
of
we don't want
movement of
foreign
healing.
body.
Yes.
Yes, yes. Stitch scissor.
So at what, this would be stage what? Having gone through
The end of the operation, because after this, we'll just transect. Show me where my scissor is. Thank you. Let's go together. Pull your pot out a bit. Show me. Okay. Good. It's always good to see where your instruments are before cutting, and have to see the tip. So, okay. So, after we put another knot, we'll just be ready to come out. But still, I have another piece of suture that's there. Will look like a foreign body. So I'll tip over the appendix.
right, for it to be cut off. Okay. So once the appendix is removed, then 101% the pain goes and all that? Not immediately, yes, but after it has healed?
Yes, if the pain was due to appendix per se, which from our dissection, there was an inflamed appendix seated there within, an appendicular mass, points towards a diagnosis of acute. Could probably have been a chronic. The inflammation might have been going on for a long time, because we didn't find pus. Yes, we just found a matted mass. Yes, so probably the lady has had antibiotics and treatments on and off as an outpatient and other facilities before she came. So probably that's why we didn't find pus. So,
What is the worst that can happen if you find pus?
find pus, we decide. If you're able to suck and release it, well and good. If you're not able to suck and release it, then I think from there, we just have to open and get the whole of it. Bring another suture.
They say that the belly button in most cases would hurt after, appendectomy.
Pardon?
A belly button, like the belly button will oftenly hurt after the appendectomy?
Not really. With the minimal access, yes, it is still a trauma to tissue, but it's minimal compared to open surgery. And even the scar, yes, the scar is minimal. Number one, Vikril. Give me another one that does not. Give another one. Peel another one, a new one.
People remember we are at the Roy Family Hospital, and we're right at the theater unit as we get to see the doctors operate on a patient, appendectomy, laparoscopy, as they would rightfully put it. And almost on the last stages of this particular procedure. If you're just joining us, not to worry, because we'll be dropping this on our social media platforms for you to be able to get a hold of the entire episode. It's been quite a smooth process so far, and that's what we're crossing fingers for, that it goes up to the last bit as we also get to understand the nitty-gritty details of this. Importantly, the aftercare, and Dr. I'm sure will be taking us through what is expected at the moment the patient walks out of the theater in terms of care until that moment where they will be healed in totality. It is a process that then guarantees healing in totality, Dr.
Yes, but occasionally you might have what we call stump appendicitis. If you leave a long stump, if you ideally should not cut it so flush on the cecum, but if you leave a long stump, it might still undergo the same process that triggered the initial pathology, and you may get something called stump appendicitis. But as medical professionals, we are still able to deal with that. Okay. Yes.
All right. So most importantly,
the other thing that can cause pain is just probably from adhesion. All types of surgeries experience some form of adhesions. Adhesions is where tissues attach to each other. That's probably the simple word I'll use. But it is less with the minimal access surgery compared to open surgery. Yes, there is still a degree of it, but it's not as...
Okay, well, we're trying to get another loop for what now?
Yes, I just want to get another loop to be sure that whatever I've tied, just for security purpose, to ensure that whatever I've tied is safer. Okay. Yes. So what I'm doing is called extracorporeal knotting. So I tie the knot, then introduce it into the, I tie it on the outside and introduce it into the peritoneal cavity. Well, ordinarily I would have used something called endoloop, a loop that has already been tied for you. It's a commercial thing. Okay. But in this case, we didn't have enough time to procure one. Okay. Yeah, so I'm just trying to introduce the suture that already has a loop in it. Yeah. Yeah, so then what I'll do is I'll again look for the loop of appendix. And sorry, I'll look for the mass of the appendix and push it through the loop. Then from there, just...
How special are these threads? Different? I've also heard you speak of number 1, number 2, and all that.
Oh, so that just depends on the size. Okay. Yes, yes. For example, if we use zero as standard, then we have anything that goes with extra zeros, like 20 is smaller than 0. Then number 1 is bigger than 0. Yes, so that's how we... Yes.
Technically, what's the experience when you're getting into any surgery room when you have to operate on a patient?
Yes. Pardon?
The experience, and I understand sometimes Daktari can be off because he has to concentrate. What is this experience like? You know, it's a different experience every other surgery that you have to conduct?
Every surgery is different. No two surgeries are the same. But psychologically, as a doctor, you have to prepare yourself. You have to prepare your patient. Yes. And when both the doctor and the patient are well prepared, then we are bound to have success. Problem is when there's a lack of communication, lack of proper patient preparation, then we are bound to have a lot of hitches. Yes. Okay.
So the aftercare, or maybe I'm taking it a little bit first in terms of, you know,
no problem.
Now after this,
Yes.
What are the do's and the don'ts for the patient?
We'll observe the patient. We are continue monitoring vital signs. They are very vital to us. Show me.
If this is left, Daktari, even before we come to the care after care, if this is left unattended, what other complications would arise?
Of course, like we said from the word go, that eventually death is an eventuality from overwhelming infections, because then if you don't sort it out, it will, as inflammation goes on, it will perforate. If it perforates, the element of fecal matter just... Sorry. There's the element of fecal matter. Show me. Sorry. Yes. Sorry for that. We'll just refix that again, so that our appendix has slipped out of the loop. We just want to ensure that we get it back in. So as I was saying, if we don't attend to this, I can't see.
It's interesting how at this point we all are crossing fingers that it gets itself into the loop, so that, yes, that's a success. Yeah, that's a success.
Let me see. We might just have gotten ourselves out of the loop. Let's just see the tip where we are. We might actually have been... Yeah, the free piece. Yes, the free piece might just have obscured our vision. And we may just have had the impression that we are in while we were actually out. Yes. Now, let me just see. Sorry, just a bit of mix up there.
And yes, like I was saying, it gets to this point and we're all like anxious and eager to see it go through.
Maybe I need to just give it a little bit of concentration. Then now I can answer your questions.
Not a pressure, not a problem.
Yeah. Okay, at this point, I'll just realign my instruments, yes. So the loop was really giving us a headache. So just decided to cut the loop and manually tie. Sorry, I didn't have my needle holders for this. But so these are not the correct instruments to tie. But sometimes when you are in intra-op, you improvise, huh? Sorry, the loops were a bit longer. I'm just releasing, sorry, one of the ends of that so that I can tie well. Yeah, so with both ends available, now I can just make a tie. I'll fasten my knot. Then can also do another one. I'll make it a slip knot though.
How many ties? So
Yes. I did not tie the normal surgical knot because I already have another loop above. And then I didn't have my needle holders. Huh? So I'll just make it a slip knot. Huh? Yes. Instead of struggling with the two loops, I just decided to tie so that we don't waste time. Huh? So now we have two strong loops. I think the thing is secure. So the upper part of it, I'll just cut off with a bipolar instrument to save time.
Okay. And the other one as well.
I'm avoiding past pointing so that I don't touch them.
And so before the notorious tie, Doctor, you were telling us, you know, the other repercussions that would occur in the event that you do not want, decide to go through this procedure. Yeah.
Well, sometimes it perforates, and the tissues will just use their natural healing mechanisms. Something called omentum will wall it off with loops of Bowen. So a patient will keep complaining of a mass like this one was after being given antibiotics. And occasionally, sometimes we do that when we think going in for surgery is not the best solution at that particular juncture. Yeah. But if the spillage is, if the perforation is much and the perforation is a lot and the spillage is much, then we risk getting something called generalized peritonitis.
Okay. I wouldn't ask what that is. I hope that someday we'll have a session.
It just means the whole of the abdominal cavity is inflamed and is full of pus and infection. Yes. So we'd want to avoid such a scenario as much as we can. So I'm just going to use bipolar energy to cut off and seal the upper part of it.
That bit is supposed to be left inside?
Yes, the other piece remains inside. Yes.
So the ties will dissolve the thread itself, not dangerous?
Yeah, they are absorbable. Yes, and the body is able to take care of them. As I cut the final end, I'm supposed to see the two ends of my instrument so that I'm not accidentally holding another piece of intestines.
Ooh. So that's it.
So we are done. So we'll get something called, we'll modify. We normally retrieve it using something called an endobag, but it's very expensive in our setting. So we just modify using gloves and remove it. Gloves, sterile gloves.
Sorry. Okay, we breathe. You go about this. And we're talking about aftercare.
Yes, so basically the patient will be nil power. That means she will not be, let me hold the camera for him as we prepare it. Will not be taking for a few hours, approximately 12 to 24 hours. We shall see. Once, okay, we'll just remove our camera out so that we can concentrate. We are careful how we handle the camera because the tip might burn the patient. It has a bit of heat there, so we have to be careful.
Lie down.
You just lie down most of the times by the back. We call it supine. Yeah, they can also lie on their left side because the right side might be a bit inflamed. Yes, and they should be okay with good painkillers. So in terms of feeding, we had said we monitor the patient's vital signs continuously. In about 12 to 24 hours, if they are okay, they've passed a bit of gas from down, their vital signs are good, and we also listen to the abdomen for bowel sounds. Then you can start liquid. Yes, so now we just hold the bag. Just to undergo testing called histology.
This will help determine what was the actual problem.
Yes, whether it was inflamed or not. I'm just trying to. Good. Let's wacha tuitoe na hapa. Umbilical statusumbua, wacha tutoe. There's no harm to increase your incision. So we'll remove it from the down port. Okay, can you see me? Okay, so I'll be pulling it into the pot and I'll remove it from that pot.
What's happening around you? Morning Cafe with heated political debates. Baraza la siasa.
Hiyo kitu azungumzie, angalie hali ya maisha ya watu.
Informative health discussions. Business. Farming. Tasty Wednesday Fitness Thursday, and Feel Good Friday with amazing DJs, celebs,
waimbaji, kuna comedians, alafu kuna wajinga.
and music bands every Monday to Friday